Hello students, today we are going to be talking about personality disorders. We're going to do an overview and then we are going to talk about some of the proposed changes that were supposed to happen in the DSM-5 that didn't. So first, what are personality disorders? So before a diagnosis is made, a person must demonstrate significant and enduring difficulties in at least two of these four areas. And those four areas are defining features of personality disorders. So these are going to be distorted thinking patterns, problematic emotional responses, it may be over or under regulated impulse control, and interpersonal difficulties. So a personality disorder is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. It's pervasive, it is not flexible, and it has an onset in adolescence or early adulthood and is stable over time, leading to distress or impairment. So a very important thing to know is that personality disorders cannot be diagnosed before the age of 18. And whenever we think about personality disorders and we think about distress, the individual with the disorder may not actually be distressed, but it may actually be others that are distressed. So, for example, an antisocial personality disorder. So, again, personality disorders are not usually diagnosed in children because this requirement within the definition is that it has to be enduring over time. And so that's why we can't diagnose before the age of 18. So let's talk about kind of the overview of the personality disorders within the DSM. There are 10 specific personality disorders. There were no changes from the DSM-4 to the DSM-5. However, there were supposed to be some very big major changes that we're going to talk about at the end. The diagnostic approach used in the DSM-5, it represents categorical perspective in that personality disorders are a distinct clinical syndrome. Some argue that you can view it as more of a dimensional manner, and we're going to talk about it at the very end of our lecture here, because this is a very pervasive extension of other disorders rather than a more transient. So the DSM, like I said, did not end up making these changes because these changes were very, very big. They'd probably be relatively difficult to put into practice. And at the end of the day, the research, just more research needed to be done before the DSM was willing to take such a big leap. So there are three clusters, A, B, and C. We're going to break down all of those. Personality disorders are very highly comorbid with Axis 1 disorders, and there is a poor prognosis if you do have a personality disorder in addition to Axis 1. I don't know that we even call it Axis 1 anymore, but everything that you've been learning about so far in this course. Personality disorder prevalence is between 0.5% and 2.5%. Some estimates are as high as 10%, which that is quite high. And then with regard to origin, features of personality disorders usually become recognizable, again, like we mentioned, in early adolescence or early adult life, and it is a very chronic course. Like I mentioned, we've got three different clusters. A is odd and eccentric. This encapsulates paranoid personality disorder, schizoid, and schizotypal. Cluster B is dramatic, emotional, and erratic. These encompass antisocial personality disorder, borderline, histrionic, and narcissistic. And cluster C is really characterized by fearful or anxiousness, and these personality disorders that belong within cluster C are avoidant, dependent, and obsessive compulsive. So we're going to start with cluster A, starting with paranoid personality disorder. For paranoid personality disorder, the individual must meet 4 of the 7 DSM criteria, and this is a pervasive distrust and suspiciousness of others, such that their motivations are interpreted as malevolent. So this person suspects without sufficient basis that others are exploiting or harming or deceiving. They are preoccupied with unjustified doubts about loyalty or trustworthiness of friends or associates, and they're reluctant to confide in others because there's this unwarranted fear that information will be used maliciously. As we continue, Number 4 in our DSM criteria is that they read hidden meanings or threats in meanings, even in very benign remarks or events. They are persistently bearing grudges, and they're unforgiving of insults, injuries, or slights, even perceived attacks on their character or their reputation that really aren't apparent to others. They are very quick to react and react angrily and even counteract. And then they are very highly suspicious without justification, especially whenever it comes to a romantic or a sexual partner or a spouse. Continuing on, the prevalence here is 2.3% to 4.4%. This is found to be more common in males. With regard to development and course, it may be first apparent in childhood and adolescence when the person is more in withdrawal or isolation. Maybe they have poor peer relationships, social anxiety. Maybe they may not be achieving as much as they could in school. They may be very hypersensitive. They have particular thoughts and language and idiosyncratic fantasies, which we're going to talk about that even more in our other cluster A personality disorders. And then these folks have an increased risk of paranoid personality disorder if they have relatives who have schizophrenia. As we continue on, some differentials that we want to keep in mind here could be other mental health disorders with psychotic symptoms, personality change due to other medical condition, substance use disorders, paranoid traits associated with physical handicaps, and then other personality disorders and personality traits. So those may be some differentials to think about as you're potentially diagnosing paranoid personality disorder. Okay, next we're moving on to schizoid. And same thing here with regard to the DSM. This individual needs to meet 4 out of the 7 criteria. And this person who has schizoid personality disorder, this is a very pervasive pattern of detachment from social relationships, restricted range of emotion in interpersonal settings. You can think about this individual as kind of your classic loner. They're socially inept. They do not take or understand social cues, and relationships to them are just simply not rewarding. They don't desire or enjoy close relationships. They prefer activities alone. They have little interest in sexual activity with others. They don't take pleasure in really any activities at all. They lack friendships. They're indifferent to praise or criticism, and they may just be very cold emotionally and be detached. As we continue on here, the prevalence for schizoid is 3.1% to 4.9%. With regard to development, this may be first apparent in childhood or adolescence with, again, similarly to what we just saw in our last personality disorder, is someone who likes to be alone, poor peer relationships, again, underachieving in school, and these children or adolescents may just be different, and maybe that makes them the subject of teasing. They may have a higher risks of schizoid personality disorder, again, if they have an individual in their family who has either schizophrenia or schizotypal personality disorder. Some differentials to take into consideration as we're potentially diagnosing this would be other mental health disorders, again with psychotic symptoms, autism spectrum disorder, personality changes due to another medical condition, and substance use disorder. Moving on, this one's a fun one, schizotypal personality disorder. And here, this person needs to meet 5 of the 9 criteria for the DSM, and this is going to be described as a pervasive pattern of social and interpersonal deficits marked by acute discomfort with and reduced capacity for close relationships, as well as by cognitive or perceptual distortions and eccentricities of behavior. So that's what's going to be really, really important here and help you differentiate between other personality disorders is this cognitive and perceptual distortions and eccentricity of behaviors. So first of all, we're going to talk about ideas of reference, and this could be they're thinking that everyone perceives in this world relates to their own identity. They may have very odd or magical beliefs, so and this is going to influence their behavior, and it's going to be very inconsistent usually with cultural norms. So maybe they're superstitious, maybe they believe in clairvoyance, telepathy, or having like a sixth sense. They also may attribute a particular event to some mysterious force, with regard to odd thinking or speech, it may be very vague, circumstantial, metaphorical, overly elaborate. So it's going to be very different compared to our other personality disorders. So as we continue to move on, we can see here that there is also going to be some suspiciousness and paranoid ideation with these individuals, again, fitting nicely into cluster A based on everything else that we've learned so far. There's going to be inappropriate or constricted affect. Their behavior or their appearance is going to be very odd, eccentric, or particular. This, again, as you saw in the very first slide for this schizotypal personality disorder, I had Charlie and the Chocolate Factory, played by Johnny Depp. And again, if you've seen that movie, he is very odd. The way that he dresses, the way that he behaves in the movie, that's a really great characteristic or description, I should say, of schizotypal personality disorder. Similarly to our other cluster A's, they lack close friendships or confidants, other than maybe first-degree relatives, and then they have social anxiety that does not diminish as they continue to become more familiar with folks, and it tends to be associated with paranoid fears rather than negative judgments about the self. And here we see another area of the DSM criteria is that this is not exclusively during the course of schizophrenia, bipolar disorder, or depressive disorder with psychotic features, or another psychotic disorder or autism spectrum disorder. So as we continue to move on and talk about the prevalence here, it's nearly 5% in a US community sample. That's quite large. And with regard to development, schizoid personality disorder has a relatively stable course with only a very small proportion of individuals going on to develop schizophrenia or another psychotic disorder. Again, it may appear in childhood and adolescence. Similarly, this person likes to be alone. They have poor relationships with others, social anxiety, they're underachieving in school, they're hypersensitive, they have very particular thoughts and language, and they have bizarre fantasies. As we continue to move on here, some risk factors would be, schizotypal personality disorder is more prevalent, again, with first-degree relatives of schizophrenia. Some other differentials to keep in mind would be mental disorders with psychotic symptoms, neurodevelopmental disorders, personality changes due to another medical condition, substance use disorders, and other personality disorders or personality traits. Moving on to cluster B, first we're going to talk about antisocial personality disorder. So here you can see the Joker from one of my favorite movies, The Dark Knight. Here this individual needs to meet 3 of the 7 DSM criteria. And with regard to antisocial personality disorder, the best way to think about it is a pervasive pattern of disregard for and violation of the rights of others occurring since the age of 15 years old. So first, this person's going to fail to conform to social norms with respect to lawful behaviors, as indicated by repeatedly performing acts that are grounds for arrest. This person is deceitful, as indicated by repeated lying or use of aliases or conning others for personal profit or pleasure, and they're going to be quite impulsive or fail to plan ahead. With regard to number 4, irritability and aggressiveness, this is going to be indicated by repeated fights or assaults. They may be reckless and disregard the safety of themselves as well as others. They are consistently irresponsible, as indicated by repeated failure to sustain consistent work or honor financial obligations. And then they lack remorse, as indicated by being indifferent to or even just rationalizing having hurt, mistreated, or stolen from others. Again, very important here, we can't diagnose until at least 18 years of age or older. But one important thing that you should keep in mind here is that there's most likely going to be evidence of conduct disorder, with the onset of conduct disorder being before the age of 15. With regard to prevalence in a 12-month period, we could see anywhere between 0.2 to 3.3%. Obviously, this is going to be more common in males. We see a very high prevalence of this, greater than 70%, when we examine specific populations such as individuals who may be in substance abuse clinics, prisons, or other forensic settings. With regard to the development and course, they may become less evident or remit as the individual grows older, particularly as we get through the 4th decade of life and even older. Okay. As we continue to move on, some risk and prognostic features would be for antisocial personality disorder, having a first-degree biological relative, again with the same disorder. Biological relatives with antisocial personality disorder are more likely to have substance use disorders. And then some differentials would be substance use disorders, schizophrenia and bipolar disorders, other personality disorders, and criminal behavior not associated with a personality disorder. Okay, let's continue to move on here. We've got borderline personality disorder. This is going to be in our cluster B as well. For someone to be diagnosed with a borderline personality disorder, they must meet 5 of the 9 criteria for the DSM. And this is going to be described as a pervasive pattern of instability of interpersonal relationships, self-image, affect, and impulsivity. First and foremost, this person is going to do anything. They're going to be very frantic to avoid real or imagined abandonment. There will be patterns of unstable and intense interpersonal relationships, alternating between extremes of ideation and devaluing the individual. There's going to be identity disturbances, like we mentioned earlier, very unstable self-image. And then lastly, they're going to be impulsive in at least 2 areas that are potentially self-damaging. Maybe that looks like spending lots of money, being reckless with sex or lots of sexual partners, things like that, substance use, reckless driving, binge eating, so lots of things like that. So let's continue to move on. And we've got recurrent suicidal behavior, gesture, threats, or self-mutilating behavior, and that's going to be something that we often see in borderline personality disorder. So as we continue to move on, we've got affective instability. This could last from a few days, few hours to a day or 2. Maybe this person has chronic feelings of emptiness and they've got inappropriate, intense anger, and coming hand in hand with that is very difficult ability to control that anger. So maybe they have very frequent displays of temper, constant anger, recurrent physical fights, and then also transient stress-related paranoid ideation or dissociative symptoms. As we continue to move on and look at the prevalence here, we're going to see that it is estimated between 1.6 and 5.9%. Whenever it comes to outpatient mental health clinics, we're going to see it at about 10%, and then psychiatric inpatient we'll see more at a 20% rate. This is a disorder primarily seen in females, up to 75%. The course with this, it is very, very unstable. The risk for suicide among young adults is very high. Episodes of serious affective and impulsive discontrol are something that we are commonly going to be seeing in this population. There's going to be very high levels of health and mental health resource use. Individuals in their 30s and 40s are going to be the majority of individuals with borderline personality disorder are going to attain more stability in their relationships and their vocational functioning. So similar to what we saw in antisocial, as the individual gets older, things start to stabilize a bit more. Okay, next we're going to continue to talk about borderline here. So some differentials may be depressive and bipolar disorders. So something that's going to be important to note is with bipolar disorder, people do move from mania to depression, but that normally takes longer, much longer, whereas with borderline, as we discussed a few slides ago, their mood changes are going to be within minutes, hours, days, so it's going to be much more frequent and quick compared to bipolar disorder. And other personality disorders, some type of personality change due to another medical condition, substance use disorders, and identity problems. So again, I like this little meme here because I think that whenever we think about personality disorder or how personality disorders, especially borderline personality disorder, may be portrayed in the media, that we do see something more so like the bottom picture when that simply just isn't the case. So let's move on to histrionic personality disorder. And with this, we need the individual to meet 5 out of the 8 criteria. And this is going to be a pervasive pattern of excessive emotionality and attention seeking. So first and foremost, this person is going to be uncomfortable in situations where they are not the center of attention. They are going to interact with others that is going to be characterized by inappropriate, sexually seductive, or provocative behaviors. They are going to display rapidly shifting and shallow expressions of emotion. They're going to consistently use physical appearance to draw attention to themselves. They may have a style of speech that is excessively impressionistic and kind of just lacking in detail. It's very shallow. And they may be kind of dramatic, theatrical, or exaggerated when they're expressing emotion. They can be very suggestible and easily influenced by others or the circumstances around them. And they consider relationships to be more intimate than they are. So this may be a throwback for some of you. This is Regina George from the movie Mean Girls. So I thought that this was a nice addition to our slide here. So the prevalence for histrionic personality disorder is going to be nearly 2%. Some other differentials are going to be personality disorders or other personality traits. And it could also look like a personality change due to another medical condition and substance use disorders. So moving on here to our last cluster B, which is going to be narcissistic personality disorder. Oh, added some music to this slide here for you. Okay. All right, so here we've got the person meeting 5 of 9 criteria. This is going to be a pervasive pattern of grandiosity, a need for admiration, and a lack of empathy. This person is going to have this grandiose they're going to have a grandiose sense of self-importance, They're going to be preoccupied with fantasies of unlimited success and power and brilliance and beauty and love. They're going to believe that they are very special and unique and that they require excessive admiration. They're going to have a sense of entitlement. They're going to be interpersonally exploitative with others, and they are going to lack empathy. Folks who have this are going to be envious of others and believe that others are envious of them. And this individual is going to be very arrogant, haughty, and that's just going to be the attitude with which they interact with the world. The prevalence here is anywhere from 0 to about 6% in the community. With males, this is going to be diagnosed at a higher rate. So between 50 and 75% of these diagnoses are male. Narcissistic traits in adolescence do not necessarily mean that the individual will have narcissistic personality disorder. In fact, having narcissistic traits as an adolescent is relatively normal for the course of being a teenager. However, this person who does have narcissistic personality disorder will have more difficulty with aging. Again, if they're going to be preoccupied with beauty and love and success and all those different types of things, especially beauty as they age, this could be very difficult for them. Some differentials here, again, we continue to see this time after time, is going to be other personality disorders and personality traits, mania or hypomania, and then substance use disorders. As we continue to move on, now we're into cluster C. The first of cluster C that we're going to be looking at is avoidant personality disorder. And we've got little Charlie Brown here on this slide. For someone to have avoidant personality disorder, they need to be meeting 4 of the 7 criteria listed in the DSM. And to describe avoidant personality disorder in a nutshell, this is going to be a pervasive pattern of social inhibition, feelings of inadequacy, and hypersensitivity to criticism. So this person is going to avoid jobs with interpersonal contact due to fear of criticism, disapproval, or rejection. They are unwilling to get involved with people unless they're very sure that they're going to be liked, and they're going to be pretty restrained in intimate relationships. So some more of the criteria from the DSM would be being preoccupied with criticism in social situations. They may be inhibited in new interpersonal situations, especially due to fears around rejection. They're going to view themselves as socially inept and unappealing and inferior, and they're going to be very reluctant to take any type of personal risks or engage with others. So I'm wondering if this sounds like any other disorders that you've learned about so far in this course. So take a moment to think about it. So this may sound very similar to social phobia and or social anxiety. Those two names kind of are synonymous with one another. So that would be a very similar personality disorder, differential diagnosis, I should say, excuse me. Oh, and very at the end of this slide here, this person may be reluctant to take risks in new activities because they're very fearful of embarrassment. All right, as we continue to move on, prevalence is about 2.5%, and the course is going to look like individuals who are going to be very shy. However, shyness in childhood, again, does not mean that this person is going to end up growing up to have avoidant personality disorder. Although shyness is a common precursor of avoidant personality disorder, most individuals tend to gradually dissipate as they get older if they're someone who has shyness in childhood. Avoidant behavior often starts in infancy and childhood with shyness, isolation, and fear of strangers and new situations. But whenever it comes to avoidant personality disorder, this is going to be very pervasive, but it may remit a bit with age. Continuing on, some other differentials could be anxiety disorders, like we talked about just a second ago, other personality disorders, personality traits, personality changes due to other medical conditions, and substance use disorders. Moving on to our next cluster C, dependent personality disorder. This person needs to meet 5 of the 8 criteria, and dependent personality disorder is best described as a pervasive and excessive need to be taken care of that leads to the person being very submissive and having clingy behavior, and they're very, very fearful of separation. So this person has difficulty making everyday decisions without an excessive amount of advice and reassurance from others. They need others to assume responsibility for most major areas of their life. They have difficulty expressing disagreement with others because of fear that they're going to lose that person as a support system or that they're going to not have approval. Continuing on, this person has difficulty initiating projects or doing things on their own because they lack the confidence in their judgment, in their skills, and in their abilities. Continuing on, they are going to go to great lengths to obtain nurturance and support from others to the point of volunteering to do things that are actually quite unpleasant. They're going to have feelings that are very uncomfortable or helpless when they are alone because of these exaggerated fears of being unable to care for themselves. They're going to urgently seek another relationship as a source of care and support when one close relationship ends. And they're going to be unrealistically preoccupied with fears of being left to take care of themselves. The prevalence for this is about 0.5%. And in situations where dependent behavior may be developmentally inappropriate, risk factors could be chronic physical illness or separation anxiety in childhood or adolescence may predispose the individual to the development of dependent personality disorder late in life. Next, we're going to talk about excessive compulsive personality disorder. So this person needs to be meeting 4 of the 8 criteria. And to describe this personality disorder would be a pervasive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of flexibility. So you already know that there is obsessive compulsive disorder. Obsessive compulsive personality disorder is quite different. So we're going to talk about a couple of different ways that these two differentiate from one another. So with regard to obsessive compulsive personality disorder, we're going to call it OCPD. This individual is preoccupied with details, lists, rules, order, organization, and schedules to the extent that the major point of the activity is lost. So they're just really, really caught up in all the details. Their perfectionism is going to interfere with their ability to complete tasks. They're going to be excessively devoted to work and productivity to the point where maybe they're not engaging in any leisure or fun activities or friendships for themselves. They're going to be so incredibly overconscientious, scrupulous, and very, very inflexible. That's going to be a key point for this personality disorder. Very inflexible about morality, ethics, and values. They are going to be unable to discard worn out or worthless objects, even when they have no sentimental value. So here that may also look a little bit like collecting or hoarding, which we've also discussed so far in this course. And then reluctant to delegate tasks or work to others unless they know that it is going to be done in the exact way in which they want it done. Continuing on here, this person adopts a very miserly spending style towards both themselves and others. Money is viewed as something that has to be hoarded, especially for potential future catastrophes. And they're going to show very rigidness and stubbornness in their life. Okay, continuing to move on here. The prevalence, this is one of the most prevalent personality disorders in the general population, ranging from about 2% to about 8%. And surprisingly, it's more common in males. And then with regard to differentials, like we talked about, obsessive compulsive disorder, similarly, it could look like hoarding, as we've discussed. Again, other personality disorders or personality traits. We keep seeing this time and time again, personality changes due to other medical conditions and substance use disorders. So I briefly touched on this at the very beginning. I'm going to wrap up our lecture with this. Proposed changes to personality disorders for the DSM-5 that did not actually happen, but I think it's important for you to know because we may see this in future iterations of the DSM. So the DSM uses a polythetic criteria for the disorders, and that means that you have to have a minimum number of symptoms. So say, for example, I kept telling you this person needs 5 out of the 9 or 3 out of the 8. So that's what we're saying here when we say polythetic criteria, is that you need to have a minimum number of symptoms from the entire list of the criteria that's required. So there's no single one symptom that is necessary, and this results in a lot of variability among patients who receive the same diagnosis. So let's just take, for example, borderline personality disorder. So I want you in your mind to guess how many different ways a person can meet criteria for borderline personality disorder. Take a moment, guess to yourself. There are 256 possible ways to meet criteria for borderline personality disorder when looking at the DSM. So that is huge. And that just is going to show that there's going to be so much variability in the way in which borderline personality disorder looks. And that's just an example for borderline. That is going to be across the board. Now, the number may differ, it may be lower or higher than 256 ways to meet the criteria. But as you saw in each of the personality disorders, that is the way in which the person meets criteria, is having, 5 of the 9 or 3 of the 8 criteria. So again, this is going to be similar for all of our personality disorders that we discussed here today, is that there's going to be many, many, many different ways to meet criteria for it. And that means that it's going to look very different across the board. So let's continue to talk more here about the dimensional versus the categorical approach. Oh, excuse me. So there is going to be a lot of co-occurrence among personality disorders, and many patients with a personality disorder tend to meet criteria for more than one. And again, when we're using this polythetic criteria, the minimum number of criteria is required, but again, there's no single one that is necessary. And that just means that we are going to have patients who range the gamut of the ways in which they meet criteria and how they look. So as we continue to move on, the way in which the DSM-5 was supposed to look was it was supposed to be a hybrid model. Now, again, this was not accepted for DSM-5's main manual. It is included in Section 3 for further study, and hopefully people will look at Section 3 as an alternative methodology. Clinicians would assess for personality and diagnose a personality disorder based on an individual's particular difficulties in personality functioning and on specific patterns of those pathological traits. So the hybrid model does retain these disorders: borderline, obsessive compulsive, avoidant, schizotypal, antisocial, and narcissistic. But then they introduce personality disorder trait specified, when a personality disorder is considered to be present, but the criteria for a specific personality disorder are not fully met. So that's something interesting that we didn't get in DSM-5, but maybe in a future iteration. And for this diagnosis, the clinician would note the severity of the impairment in the personality functioning and the problematic personality traits. Now, how are we going to measure this? Well, there was supposed to be a personality inventory for the DSM-5 called the PID-5, and it was going to be 220 items. Again, this is still a work in progress. It was going to be a self-report option, an informant option, and a child option that had a full and a brief version. And the brief version was going to be 25 items compared to the full personality inventory. It was going to be rated on a 4-point scale of 0, very false, to sometimes somewhat true and very true. And then you score on the 25 trait facets and the 5 domains. One of the reasons why this was not picked up for the DSM-5 was that many feared that clinicians, researchers, and insurance companies, as well as clients, would not be accepting of this new system, and that's why it didn't make it into the DSM-5. It's going to take more time for this to be an acceptable option for folks. Nonetheless, like I said, it is in Section 3 if you want to explore it and learn more about it. But that is it for our personality disorders lecture. Thank you for your time and attention, and I'll see you in our next one.